Hey, how you doing over there, Worm Shock?
I'm doing pretty good. It's hot. It's hot.
Yeah, what you drinking on?
When I get into my warm shock, hot shock state, I like to have me a little bit of norepinephrine.
Hang on a sec. That'd be epi for me over here with cold shock.
Well, cheers to you, cold shock.
Oh, I love the visual, and I will have to say, I maybe will never be able to unsee warm shock there for us. So we're talking about pediatric shock, and as with all things with kids, it's a little bit unique. So let's dive right into it, shall we? So pediatric shock is thankfully not super common, but because of that, I think it can be easy to miss, and they don't always follow the rules like adults do. So did you know that you don't even need hypotension in kids to diagnose shock? And oftentimes they won't even be hypotensive. So what is shock? Shock is basically a state of balance, right? It's inadequate oxygen supply to meet the body's cellular demands. And there's really four main categories of shock. Hypovolemic tends to be the number one common cause of shock in kids. Distributive, cardiogenic, and obstructive. We're going to talk about each of these four main categories. I already told you hypovolemic is the number one cause of shock in kids, usually from acute gastroenteritis. They lose so much fluid that they'll actually become hypovolemic from that. So if you are starting to see signs of hypotension, tachycardia, etc., after diarrhea, or perhaps even hemorrhage or burns, and this is something you need to think about. Hemorrhagic shock in kids is another subform of hypovolemic shock. If you're seeing that in a kid with an unclear history of direct trauma, like a motor vehicle accident, then you actually need to be thinking about child abuse, and we've talked about that before. Distributive shock is from inappropriate relaxation of the peripheral vascular tone. So you get vasodilatation leading to hypovolemia. This is pretty common, most common cause. Sepsis is usually the number one cause of that, quickly followed by anaphylaxis. It can also be caused by neurologic injuries and drug-related. What happens clinically? Well, these patients will show up altered. They may have a delayed cap refill time. They will have decreased urinary output. And as mentioned before, hypotension is not required for the diagnosis of septic shock in kids. And all infants under the age of 3 months are presenting in shock should be considered septic until proven otherwise, right? They don't have that nice blood-brain barrier in kiddos. All right, so I'm going to talk to warm shock and cold shock. So cold shock, Robbo. You are someone that would have high systemic vascular resistance. So you're going to have cold hands and feet, cool extremities. You're
Cold.
Going to have super cold. You're going to have delayed cap refill.
Very
You're
delayed.
going to have diminished peripheral pulses.
Where'd they go?
And narrow pulse pressure. So everything is going to be cold and slow for you. Moving on to warm shock. So you, de Klerk, have a low systemic vascular resistance. You have warm, dry extremities. You're hot, right?
Yep.
You have brisk cap refills, you're tachycardic, you have bounding pulses with wide pulse pressure.
It's like Robbo's pulse when he sees me.
That's right.
Bounding, tachycardic.
Okay, third type of shock is cardiogenic shock. And we see this more in adults, to be quite honest, but it can happen in kids, particularly if they have congenital heart disease or any of those underlying cardiomyopathies or arrhythmias. But it's basically something that impairs their cardiac output. And lastly, obstructive shock. Again, less common in kids, more common in adults. In adults, we see this, with tension pneumothoraces or massive PEs. In kids, you can see this with ductal-dependent congenital heart lesions, and that can lead to an obstructive shock, and usually happens in the first few days or weeks after birth. So just know that it can happen. Across the board, pediatric shock in kids, they will present as kids typically do with nonspecific symptoms, which is never helpful. So lethargy, fussiness, tachycardia, decreased urine output, poor feeding. These can be some of the signs that you'll see. Persistent tachycardia in a calm afebrile child should always be a red flag. Like that is basically shock until proven otherwise. You may see this delayed cap refill depending on if they have cold or warm shock. And by the time kids are hypotensive, this is why we always say kids are okay until they're not. Hypotension is sort of one of the end signs that they're not able to compensate anymore. So point of care ultrasound at the bedside is super helpful. Most of us are pretty astute in this at this point, and really looking at that IVC and how collapsible or how deflated it is really important in order to see how dry that patient might be. What's the first line of treatment, you guys, for any type of initial shock?
Fluids.
Fluid.
I think we're in agreement on
That's
that one,
right.
buddy.
And so even if you are suspecting cold or warm shock, you're going to start with that initial 20 cc's per kilo of fluids. And the push-pull method is really, you can pull out 20 cc's out of a liter and slam it in. So pull it out and push it in is really a great way of hydrating kids quickly. Now, if you think this is cardiogenic or you're starting to see signs of fluid overload, then you want to back that down a bit, right? To like 10 cc's per kilo. But initially, giving a 20 cc per kilo bolus is fine. And you can repeat that up to 60 cc's per kilo before you move on to pressors.
Either you guys ever done or seen this push-pull? I had read about it the first time in this article. I'd never heard of it or seen it, this three-way stopcock thing. It's just, and I wish I had decades ago.
Yeah. I use this. I love this method because it's just easy. Rather than having to like hang it on a liter and trying to calculate off the liter, you just pull it off the syringe however much you need and you literally push it in. It's great. So this is an important slide. Who's cold shock? Robbo.
I'm cold shock with my stein of epi.
And your cold shock, you have, right, your cool extremities. I'm going to treat you with epi as your first pressor after I've given you fluids.
Little sip of that epi.
That's right. And warm shock with your awesome red hair. If you are bounding pulses, warm, dry extremities, I'm going to be giving you norepi.
Oh, take a drink, my friend.
Ice cold norepi.
Now, you may need to intubate these kids. And just like any time you intubate anyone with any type of shock, you want to resuscitate before you intubate, right? So these patients are hemodynamically unstable. So giving a medication such as ketamine or etomidate is going to help you to help sort of minimize or mitigate that hypotension that you don't want to send them into worsening state. Obviously, you want to give broad spectrum antibiotics for any patient suspecting for septic shock, and giving stress dose steroids is important as well. So what's your endpoint? How do you know when you're sort of done resuscitating? Well, Surviving Sepsis Campaign identified these goals: that you should have good cap refill less than 2 seconds. You should have normal blood pressures and pulses, again, age appropriate. They should have warm extremities, so closer to a warm state like de Klerk is, and they need to start making urine. That's how you know that you're sort of hydrating them and resuscitating them appropriately. And certainly their mental status should come back. Now, we typically don't get to see that in the emergency department, but likely in the PICU, those are your therapeutic endpoints. So in summary, hypotension isn't required for the diagnosis of septic shock in children. That's really important. Persistent tachycardia, particularly when they're not febrile, is always concerning. The first treatment of choice for shock should be 20 cc's per kilo, ideally that push-pull method. You can give up to 60 cc's per kilo. And Rob, if you are cold, I'm going to give you epi. And de Klerk, for warm shock, I'm going to give you norepi.